Hello everyone. Today would be discussing a video on a patient presenting with hypertropia and hemianopia. What next? 46-year-old gentleman came to us with squinting and diminution of vision following a road traffic accident in 2007. He was treated elsewhere for CSF rhinorrhea followed by meningitis. CT scan report of then showed a pneumocephalus with an asoethmoidal complex fracture. Patient was a known case of traumatic optic neuropathy in the right eye. He had undergone a multiple lid surgeries in the left eye and also undergone a pars plana lensectomy and vitrectomy for dislocated lens in the left eye. He had also undergone a SFIOL recently in July 2021. Examination showed a best corrected visual acuity of 630 N24 in the right eye, 612 N8 in the left eye. The ocular movements showed a limited adduction and a limited depression in the left eye with a primary case position of a left hypertropia and a left exotropia, measuring around 45 prism diopters of L/R with a 30 to 35 prism diopters of exotropia. Anterior segment of the left eye showed enophthalmos with a retracted upper lid and a notch, a dilated, fixed and an updrawn pupil with an SFIOL in place in the left eye. Fundus examination showed a right eye optic atrophy with the left eye also showing a pale disc and a peripapillary atrophy just reaching the fovea, OCT showing the evidence of same. Visual fields of the right eye done with the full field stimulus 5 showed a temporal hemianopia spilling onto the inferior field, and in the left eye showed a temporal hemianopia again. A 10-2 program was also done which showed a temporal hemianopia just sparing the center in the left eye. So to summarize, the challenges in this case was left eye being enophthalmic, being the only good seeing eye. The patient had undergone multiple surgeries, so the risk of scarring and bleeding. Hemianopia, though not reaching the center, had a large hypertropia and exotropia. So the possible options would include a neuroimaging to find out where is the what is happening with the inferior rectus in the left eye, FDT and FGT in the OPD and intraoperatively in the left eye. Undercurrenting XT may be acceptable in view of hemianopia. Limiting the surgery to two recti muscle is important to prevent the ASI or anterior segment ischemia. Modified Nishida's procedure is definitely a consideration. Transduction test of the left eye showing a tight superior rectus. Superior rectus muscle was hooked and isolated. Hemi-hangback procedure of 4+4 mm was performed. Inferior rectus muscle was explored. It was found the inferior oblique muscle was in the place of inferior rectus and no inferior rectus fibers was found. This was probably because of the previous surgery. Now with the absence of inferior rectus muscle, superior rectus muscle already recessed, we just had option of one muscle to correct both the exotropia and hypertropia. So a single muscle modified Nishida's procedure was done on the lateral rectus muscle. Lateral rectus muscle was hooked and isolated. A non-absorbable ethibond suture was placed 10 mm behind the lateral rectus muscle, and the same suture was passed on the sclera in between the lateral rectus muscle and the inferior rectus muscle 12 mm